Welcome to the Her Story Circle podcast, the podcast that brings you the extraordinary tales of everyday women who are changing the world. I'm your host, Gertrude Mache, and I'd like to acknowledge traditional custodians of the land on which we meet today. I also like to pay my respects to elders, past, present, and emerging. Every week, we dive into the lives, challenges, and triumphs of women from all four corners of the globe. We're here to inspire, enlighten, and connect, sharing stories that uplift and empower. So grab a cup of coffee, settle in, and join us as we explore the incredible journeys of women shaping our future. This is Her Story, where every woman's voice matters. Hello, everybody, and welcome back to the Her Story Circle. This is Gertrude Mache here in beautiful Melbourne, Australia. As you know, the Her Story Circle is bringing you stories from all over the world, experts on all types of issues related to women's healthcare, businesses, etc. Today's guest is focused on women's health. Please tell everybody your full name, where you're based, and share your story with us today.
Well, hello everyone. My name's Susan Davis. I'm an endocrinologist, which means I'm a hormone specialist and a medical researcher. And I'm also based in beautiful Melbourne, although today was pretty horrible with our tropical sort of weather. But back to women's health. I never really planned entering women's health specifically. I trained in medicine in Melbourne at Monash University, and really by serendipity through working with a woman called Jean Hales, who set up the first menopause clinic in Melbourne, Australia, I became interested in the menopause, and working with Professor Henry Berger, who was an international leader in the field, I then progressed into doing a PhD and specializing in the field of menopause and women's health. It's been an exciting journey. I'm one of 5 people that set up an organization in Australia called the Jean Hales Foundation. And that organization, which I'm now still associated with, probably is Australia's leading group in educating women and doctors about menopause. So our research looks at how women experience menopause, but we look at it really across the lifespan, because what happens in a person's health today is very much influenced by what's happened to their health in the past. So you can't just take a snapshot in time of somebody's health, but have to understand the progression of health across the lifespan. So this has led us to look at hormone levels in women across the lifespan and how they relate to symptoms, and how women experience menopause even in different countries. So, for example, we've done studies in Bangladesh and Iran and Australia, and what we've shown is that the experience of menopause doesn't really differ as much between countries as people have thought. The experience in terms of symptoms is often not very different, but culturally how people interpret those symptoms or how those symptoms might impact their lives is sometimes quite different. So biology is very much the same, but how it impacts people varies according to cultures, expectations, and experiences. A lot of my work has also been involved in testosterone in women. So I first thought it would be very strange to treat women with testosterone, and investigated the effects and side effects of giving women testosterone. And over the years, work I've done and done with other people has shown that testosterone is indeed a very important female hormone. It's important for aspects like sexual function, but there's still so much we do not understand about it. So our ongoing research is looking at the role of testosterone in cardiac function, in muscle strength, and in bone health, and also the effects on sexual function in younger women. So the issues are what we know and what we don't know. And unfortunately, we still don't know enough about hormones in women. We're also doing studies about menopause and how it affects women in employment. A lot is said about the effects of women in employment. A lot of is said about menopause and the effects on women in employment, but the available data is insufficient to really make broad general statements about this. Particularly, we don't really understand if menopause affects women in terms of work engagement, or whether their roles of carers, or whether their roles in terms of looking for work. So how menopause impacts either women's remaining in work, the hours they worked, the type of jobs they do, or whether they are able to rejoin the workforce after exiting to have children, remains completely uncertain. I do feel very concerned that there's a very big push to insert workplace policies about menopause and work urgently. And I think we should be very cautious about this, because we don't want to stigmatize women, and particularly stigmatize women at midlife or women who are struggling with menopausal symptoms. So I think we need a lot more research in this space. The other area in which there is a dearth of understanding is the impact of being a refugee or asylum seeker on health, particularly in terms of women's health. So a study that we're undertaking together with collaborators is the women's health needs of women in Australia who are refugees or asylum seekers. This has not been well studied because women in these circumstances have no real social status. So being able to talk to them is really important, and to be able to understand how their personal experiences interacting with their culture and their change of cultural circumstances impact their health. The other area of uncertainty, of course, is not only hot flushes and night sweats and life for women, but what other symptoms at menopause are valid symptoms, and what other symptoms at menopause merit treatment with hormones. Women often talk about the whole 50 symptoms of menopause. And this is complicated because menopause occurs at a time when women are experiencing symptoms for a whole array of reasons. So at midlife, everyone who has depressive symptoms cannot be sure that those depressive symptoms are due to menopause, for example. There are a whole host of reasons why women might have depressive symptoms at midlife, and therefore a person needs to be looked at as a whole person rather than just honing in on saying, oh, it must be due to menopause, and if you have estrogen, you'll feel better. Doing that really misses the opportunity to truly understand the determinants of that woman's menopausal or depressive symptoms, and best treating those depressive symptoms. So I'm really saying that everything that occurs at midlife or around the time of menopause is not necessarily due to menopause. And if we keep thinking it is just due to menopause, then we might miss either the biological reasons or the environmental reasons that can be modified to improve a person's health.
Wow. Dr. Susan, you've touched on so many aspects of women's health. I want to first of all delve into the impact of sex hormone research. Can you elaborate on how your research on sex hormones has transformed our understanding of women's health across their lifespan?
So I think the main findings we've had is understanding that, for example, testosterone actually starts to decline from the age of about 20, and testosterone blood levels fall in women between the ages of 20 and 40 years by about 25%. Why does that matter? I don't think that's the cause of sexual dysfunction or the cause of mood change, but that does show that testosterone is an integral hormone for women, and it does probably relate to progressive decline in fertility in women at this time. So testosterone is really important for ovarian function, and it changes with age in young women. The other thing that we've shown in very recent years is blood testosterone women aged 70 to 90 is the same as women aged 20 to 40.
Okay.
Testosterone is not just an important hormone for young women, it's an important hormone for older women. And we've shown that low testosterone in women over 70 is associated with a greater risk of heart disease. So
Wow.
we're trying to understand what is the biological role for testosterone on the cardiovascular system and on other bodily functions, not just thinking of this about a sex hormone or a reproductive hormone.
So your clinical trials were instrumental in the approval of testosterone therapy for women. Can you discuss the significance of this therapy and its impact on women's health?
So I've led trials conducted in Australia and internationally where we've shown that for postmenopausal women with low libido, giving a low appropriate female dose of testosterone therapy does in fact, in general, improve sexual function, improves libido, arousal, orgasm experience, etc., of women presenting with low libido. So that work was, as you said, pivotal in the approval of testosterone as a treatment for women in Australia. And we do now have a testosterone product in Australia. We are the only country in the world with an approved testosterone product for postmenopausal women. In fact, we're the only country in the world with an approved product to treat postmenopausal women with presenting with low libido. And I think that in itself highlights how underappreciated and under-researched this whole field is for
Yeah.
women.
Wow, that's incredible. Congratulations for that. So, how has your research contributed to the advancement of menopause management? And what key findings would you like to highlight?
So we've done a lot of different studies, and to summarize them in a sentence is very difficult.
Yeah.
But what we have done recently, and I think it's really important, is we have reviewed the world literature pertaining to guidelines for what are the indications for menopausal hormone replacement therapy and what are the risks. And we published this initially in 2014, and we've completely reviewed it and revised it and republished the revised version in 2023 as the Practitioner Toolkit for Managing Menopause. And it is internationally endorsed. And I think the most important thing to recognize is the absolute cardinal symptom of menopause is hot flushes and night sweats and vaginal dryness and loss of libido.
Right.
And that these are the cardinal symptoms where one can really hang your hat and say these are symptoms where estrogen therapy is justified. A lot of the other symptoms really blur into what is happening to a woman's life. And yes, low mood and anxiety can be due to the hormonal changes,
Mm-hmm.
but estrogen is not going to fix everything in a woman's life. And symptoms like brain fog, for example, are
Yes.
due to a whole range of things. And what we need to be looking at is what is happening to a woman at midlife. And women experience menopause when they're sandwiched between children and parents. They're doing jobs. 80% of women are employed now when they go through menopause worldwide,
Yes.
whereas 40% 30 years ago. So women are working. They're the linchpin of their family. They're under financial stress. Everything's happening in their lives. And we shouldn't just say, oh, we'll have some estrogen. Everything will be better. It's not that
Yes.
simple.
Now, your work at Monash University As the head of the Women's Health Research Program, what are the primary goals of the program and what future research directions are you focusing on right now?
So our goals are to really understand how hormones affect women across the lifespan. So one of the areas that is poorly looked at is the health of women aged 40 to 69. So we're doing, one of our goals right now is heeding a national study we did a few years ago where we're recruiting women aged 40 to 69 to complete a really detailed, comprehensive women's health questionnaire, and where we're also collecting blood samples, because I mentioned earlier we've looked at women aged up to 40 and we've
Yes.
looked at women aged 70 plus, and we've measured hormones using a very sophisticated technique called LCMS. We've
Okay.
never measured hormones in women aged 40 to 69 with such precision, and we're doing that presently. So
Wow.
we're going to go back and look at and say, how do hormones change when measured really precisely in women at midlife? Because that's never been properly documented. You think it has, but it hasn't. And we're looking again in detail at how are women affected by menopausal symptoms today, post-COVID. What are women doing about it? What are drugs are they using? What's the prevalence of depression and depressive symptoms? What's happening to women in the workplace? How is menopause affecting their work? And these are the questions that we're really addressing now. And currently, we're also doing several clinical studies as well.
That's just incredible. So, how does your work as a consultant endocrinologist inform your research and vice versa?
Oh, it's critical to be practicing medicine in the field, because when I see a patient and I'm like, I don't know how this drug works in this patient,
Yes.
or, oh, does testosterone really improve muscle function?
Yeah.
I don't know. So that makes me think I've got to do a study. So we're doing a study called the Pamela study, which is women aged 55 plus, and we're looking at whether testosterone versus placebo improves muscle function and strength. So my practice about saying I don't really know what testosterone does for muscle function and stress informs the research question. And then we
Yes.
get to the research, and the answers inform this practice guideline. So we're doing clinical trials involving women aged 35 to 70. And if anyone's interested, or 35 to any age, we'd love to have people participate in our studies.
Okay. So, as one of the founders of the Jean Haley's for Women, what was your vision for the organization and how do you see it evolving?
So when we started Jean Hales, it's a pretty big organization now. It
Mm.
was set up by 5 people putting $200 in a kitty in my living room.
Oh,
And we didn't know what we were setting up. We thought we might actually raise money for a scholarship. And then
okay.
when we realized that nobody's going to give money to people to a scholarship for research into menopause, we then set up a clinic. And we were shocked by the need for the clinic. And we set that up in Clayton. And then we thought there might be some need for education. And a very kind woman called Iris Lustig, whose family then owned the Hyatt Hotel in Melbourne, donated the ballroom of the Hyatt Hotel for us to have a luncheon and
Right.
talk to women about menopause. And I think we were sold out in about 10 days. And then we said, we better do a second one. And we did a second one. And then suddenly we realized women were desperate to learn about menopause. This is back in the early 90s.
Okay.
And so that really made us aware of how desperate people were for information.
Yes.
And that really was the birthing of the education program of Jean Hales, which then has morphed into online education, physician training, a whole range of things. And it was fundamental to understanding the needs for knowledge, or the unmet need of knowledge.
Yeah. Wow. Now, throughout your career, you've been a strong advocate for women's health. What are some key issues you're currently focusing on in this area?
Um, I'm I'm very concerned about misinformation.
Mm-hmm.
I think it's very difficult for people in the community to identify what is highly credible information and separate that out from, um,
Yes.
I guess, self-interest advocacy. So you've
Right.
got, TikTok, for example, or Instagram is fantastic as a means to communicate good information, but it's very difficult to separate out misinformation. And
Mm-hmm.
and so I'm a strong advocate for organisations that provide credible information, and organisations in Australia for that are Jean Hales and the Australasian Menopause Society in the field of menopause, and
Yes.
trying to help people understand where information may be misinformation. And that's usually where somebody has some personal agenda or benefit.
Yeah.
Or
Yeah.
if somebody's evangelical about information,
Yeah.
then,
A red
I
flag
do this
should.
so it's going to work for you.
Yes.
Don't do this because if someone's got a financial gain for what they're telling you, or if
Mm,
someone's evangelical about a particular approach, be cautious.
okay. Yeah.
And
Right now with social media, it's very difficult to discern what information to trust and what not to. So that's a very good tip.
and then the other areas is physician education, because around 2002, when the Women's Health Initiative was released, and the headline news was HRT caused breast cancer, not only did women stop taking HRT, but doctors stopped prescribing it, and the education programs for doctors stopped talking about menopause. And so we have a whole generation of healthcare providers who
Mm-hmm.
do not know how to deliver menopause-related healthcare. So
Mm-hmm.
I am working very hard with colleagues to upskill doctors, and we in fact have a program that's funded by the National Health and Medical Research Council that is helping to upskill GPs in the delivery of menopause-related healthcare.
It's fantastic. So, what was your approach in advising on the Australian National Women's Health Strategy? And what are the key areas of focus in this strategy?
Oh, Helen's piece of string. I mean, the key areas of focus are indeed um, about recognizing the major issues for women and the unmet needs. So, and they vary across the lifespan. So the whole issue of menstrual dysfunction that is not well addressed in primary care, whether it
Right.
be endometriosis or PCOS or early menopause, etc.
Yeah.
Um, Midlife women, there are different key issues, and again, health factors and reproductive factors that impact women on healthy aging. And so that's really important. But very much the National Health Women's Health Advisory Council, rather than looking at individual problems, are trying to look at systemic problems that are
Okay.
affecting women's health. So if a woman goes to the emergency department with a condition like a stroke or a heart attack, will she be treated differently to a man? Do we understand stroke and heart disease in women as well as in men? So what are the systematic problems in the health system rather than just single diseases?
Okay. Wow. It's interesting because you don't really think about that you present yourself at a hospital, depending on your gender, the reaction will be different. I'd never even thought about it in that way.
Oh, we do know that, um, for example, heart attacks in women present differently to in men. Men often have the classic central chest pain, going to the chest, going down the arms, sweating profusely. Women
Right.
might just feel nauseated and really, really unwell, and maybe have upper abdominal pain. So often the symptoms in women are quite different.
Yeah. Yeah.
And even the pathology in women are slightly different. So men are more likely to have big coronary arteries that are blocked, whereas women are more likely to have little arteries that are blocked. So it's quite different.
Different, yeah. So can you share your experiences working with the national and international regulatory bodies like the FDA and the TGA in advocating for women's health?
Well, regulatory bodies generally do not see their role to advocate to they don't see their role to provide so much new drugs to the community. They're almost the gatekeepers of drugs. So, for example, the TGA in Australia, to their credit, in my opinion, did approve testosterone for women in this country. In the
Okay.
US, there is this roadblock against approving it for women, and yet several million prescriptions off label of male testosterone are being written for women in the US every year. So they see their role as not to protect women from all these adverse effects of off label prescribing, but rather to be the rigorous
Yeah.
gatekeepers for new drugs. And there are gender issues in equity about what's approved for men and what's approved for women. I mean,
Yes.
Viagra was approved just like that. And drugs for female sexual dysfunction are just it's like pushing cement up a hill.
And in fact, the doctor who put me onto you was talking about exactly that. It's just shocking,
Oh,
absolutely shocking.
there's definite gender inequity in the approval of drugs for men and women, and particularly in the area of sexual health. You know, the
Yes.
fact that there are multiple drugs approved for male sexual dysfunction by the FDA and not one approved for postmenopausal women as in the US is extraordinary. Just
Yeah.
extraordinary.
Yeah. That is crazy. So, my last question for you: what advice would you offer young researchers who are interested in pursuing a career in women's health research?
Well, I think firstly, you've got to have a fire in your belly to do research. Research
Yes.
is not for the faint-hearted. A career in medical research is not for the faint-hearted. You've really got to have an inquiring mind. If you're not a person who likes puzzle solving or detective work, and if you can't find the answer immediately, just prepare to keep going like a dog with a bone, then
Yeah.
research isn't for you, because you've got to want to persevere. And then the other issue is you've got to stay in touch with the community and make sure that what the research questions you're asking matter to the community. Otherwise,
Yeah.
there's no point. If research doesn't get translated into health outcomes, what's the point of doing it?
Yeah. That's so true. Wow. Thank you so much, Dr. Davies, for coming online today and gracing us with your presence and your knowledge. You have shared a wealth of knowledge here that I'm pretty sure my community will appreciate. Really, thank you for the time that you spent with us today.
Oh, it's an absolute pleasure, and I hope it's of interest to others.
Definitely is. And thank you to everybody who's tuned in today. The Her Story Circle is bringing you experts, professionals in all aspects of a woman's life. Dr. Susan Davis is looking for people for her research. How can we find you? Is there a website I can direct people to?
If people simply Google Monash Women's Health Research Program, they will find all about what we do and the research we're doing.
Fantastic. Thank you so much. I'll be back again tomorrow, everybody. Please have a fantastic day wherever you are in the world, and bye for now. Thanks again, Dr. Davis.
Thank you.
Thank you for tuning into the Her Story Circle podcast. I hope today's story has inspired you to believe in the power of our stories and the difference you can make in the world when you use your voice. I'm Gertrude Mache, and it's been an honor to share this space with you, where voices from all walks of life come together to weave a rich tapestry of diverse perspectives. Don't forget to subscribe, rate, and review our podcast to help us share these stories with more listeners. Follow us on social media by looking for the Her Story Circle podcast for more updates, and join us tomorrow for another episode filled with courage, resilience, and empowerment. Remember, your story matters, and together we're building a stronger, more inclusive world. Until next time, keep making